Bella.
Good afternoon, everyone. I think we're going to go ahead and get started. We'll leave the door open so people can trickle in on their way back from lunch. I'm Mike Frick. I work with Treatment Action Group in New York, and it's a real pleasure to co-chair this session alongside my colleague Kristen, who works at ERIS in South Africa. We're talking about using good participatory practice, what we call GPP, to bridge the gap, engaging researchers and communities in the fight against TB and in TB research in particular. So today's session is really special for a couple of reasons. I was told yesterday that this is actually the first time at either an HIV or TB conference that GPP has gotten its standalone oral symposium session. It's been in plenaries, it's had abstracts, posters, but it hasn't had a session dedicated to itself yet. And we have both researchers and community representatives on our panel today, so we're bringing everyone's voice to the front. Today's also notable for another reason, which is that ERIS is launching its new good participatory practice guideline for TB vaccine trials, the culmination of probably over a year's worth of work that I'll let Kristen talk to you about before we get into the abstracts.
Great. Actually, I'm going to do it from up there because this is important for us. All right, so we wanted to just take a moment to explain to you why this is so important to ERIS. So my name is Kristen, as Mike said, and I work for ERIS, which is a product development partnership which aims to develop a new TB vaccine accessible to those who need it. For ERIS, it's really important that we have strong partnerships with governments, with funders, with sponsors, and with community. And for us, we believe that in order for us to work together properly to ensure trials are developed, designed, and conducted appropriately, and to ensure that they are relevant to the communities that need them, we believe that we need to make sure that these partnerships are strong. We also want to make sure that communities are appropriately prepared to be able to participate in and advocate for the research agenda. So to that end, we developed good participatory practice guidelines for TB vaccine research specifically, also known as GPP TB Vac. Today is officially the launch of GPP TB Vac. So after today, you'll be able to get those guidelines on our website and also on AVAC's website. And there are plenty of copies on the seats and at the back. And we actually encourage you to take as many copies with you as you can and distribute these guidelines. So just to tell you briefly how we developed these guidelines, it was a very participatory approach. We had the help of AVAC, and so we have representatives of AVAC sitting here, and we're really grateful for the support that they gave us. But the development was led by ERIS and done through participation with a number of stakeholders. And I actually just want to take a moment to thank some of those stakeholders who were involved. So we had SATFI under UCT, we had Aurum Institute, we had TAG, Mike sitting right here with us. We had, let me get all of them correct, the Critical Path Institute, Advocacy Prevention for HIV/AIDS, and also the CABs. We actually sent this out to CABs to review. And each of those stakeholders really gave us their insight and their experience, which have resulted in a really high quality document. Now, GPP guidelines have been developed to be a framework and a systematic guidance on how to effectively engage stakeholders from trial design right through to results dissemination. So we are very, very pleased to say that as of today, GPP TB Vac is officially launched and available to the communities. So So we have a few speakers today who are going to tell you their experience of implementing GPP, and specifically how to bridge the gap between researchers and communities. So our first speaker is Jessica Salzwedel. Jessica is the program manager at AVAC. She focuses on developing innovative tools for AVAC and UNAIDS for GPP and supporting their implementation. Her role involves developing online materials and course materials for GPP, as well as doing a peer-peer, let me get this right for you, Jessica, a peer-peer engagement space. So Jessica has been really involved in the GPP TBVAC development, and I think she's perfectly positioned to give us an overview of the history of GPP, how it was developed, how it's been effective in biomedical research, and specifically how we got to the point of GPP TBVAC. Jessica.
So thank you, everybody, and thank you so much to Eris for inviting me here. So I'm going to, as Kristen said, talk about where we've been, where we're going, and really try to put good participatory practice into context for you. There we go. So this is what we're going to talk about, the history, a little bit of the state of the field, and really about how this is the moment. And then really, what is the future of good participatory practice in biomedical research? I'm also going to talk a little bit about what GPP is for some of you that don't know. So first, just a little timeline, and I will go into some of these issues in depth. But just to where it all sort of began was in 2005. There were PrEP trials. PrEP is pre-exposure prophylaxis in the HIV space. It's taking medication to prevent HIV in an uninfected individual. And these trials were actually stopped, and I'll go into more detail in a minute. But from that, 2 years later, UNAIDS put out an ethical considerations guideline, and in companion to that was actually the first GPP. There's no picture because it wasn't as beautiful as it is now and continues to be through Eris. But through that process, there was actually more stakeholder consultations, and in 2011, we have what we see here, which is GPP HIV. The second edition was actually published. That same year, the U.S. Bioethics Council, and this is the President's Council on Bioethics, actually named good participatory practice as a gold standard. So this is the first time we saw it really recognized by a body outside of those practicing or those doing research to say, this is ethical and this is really important to research. In 2012, this is the first example of a country that took on GPP, and so this is Thailand giving comments on the GPP HIV. You'll hear a lot of GPP HIV, a lot of acronyms is through here. But so this is the first time a country really took whole ownership of it. That same year, drug trials also came out with their own good participatory practice. In 2016, emerging pathogens, just last year, published their own version. And then we're getting more towards the present, where we recently had a think tank, and I'm going to go over some of the future, what we think about GPP for the future here. Oh no, sorry, it's missing a document. It should actually talk about, Eris is also published in 2017. So here I'm going to also just explain what is GPP and I'm going to start off with where we've been. So the beginnings are really these early PrEP trials that I mentioned, once again, pre-exposure prophylaxis, and this idea that there was controversy. These trials went through a very standard review process. They saw an ethics review committee. In HIV, community advisory boards are a standard part of a trial and have been since the late 80s. And so this went through a very standard process. They thought that they had engaged community, and I would say that in air quotes. But what we saw was that advocacy groups, in this case, these trials were dealing with female sex workers, and advocacy organizations thought, actually, I do think that these trials are exploiting these sex workers. The participants themselves felt comfortable in it, or felt comfortable with the trial, the limited that had been involved. But we saw that it actually spiraled to a much bigger piece, and this is at an IAS in 2005. These are at an AIDS conference where these are big banners. This is Gilead, who is the drug producer of PrEP or Truvada. They actually just were shutting down the booth with protests, and advocates really took over. So from that, like I said, there was this need, well, something else seems to be missing. And from there, we really got to this idea of the UNAIDS ethics consideration in biomedical HIV prevention trials. And in particular, GPP was birthed out of this guidance point 2 on community participation. As I mentioned, you can spend some time reading this, but as I mentioned, this was published in 2007, and we're here in TB, so I wanted to give a little bit of a broader context. In 2016, the CIOMS guidelines actually came out and specifically talk about meaningful participatory process. And so while they don't call out good participatory practice explicitly, they do call out the process of engagement and engaging multiple stakeholders throughout a trial process. So why GPP? There's lots of guidelines out there. Do we really need another one? So just to sort of give you that history of how it got created, we really think about good participatory practice in a set of guidelines is because clinical research with community stakeholders is just another part of trial conduct. And in the way that we have good clinical practice, good manufacturing practice, good laboratory practice, we do need a set of guidelines that really help inform the relationship between research entities and broader stakeholders. And the guidelines were developed to facilitate an effective building relationship. And in particular, when you look at the beautiful TB VAX guidelines that you have in front of you, you really see a blueprint on how to roll those out, so moving from theory to practice. And in particular, we just don't want to confuse participatory practice with participant practice. And it's really key to think about this as a much broader entity. So GCP, not GPP. Anne Schley actually did this graphic, and I love it, so I use it quite a bit. But this idea that good clinical practice is not good participatory practice. For those of you that are clinicians, you might think, okay, well, we already have a set of guidelines in how we interact with our trial participants, but it's much broader than that. As I talked about in the example, it's advocates, so these non-trial participant entities that were able to stop and delay progress on drug rollout, really on drug trials. And so you have to think about broader examples. We've all heard media stories or inflammatory things that happen in the media, rumors that spread. We were in a community session yesterday where somebody said that in a protocol, if it says that you can't take contraception or you have to take contraception, the community thinks that means that the drug is going to make you sterile. And so we have to think through what are rumors and how do we engage a broader set of individuals so we really can connect and build these relationships. So I keep using stakeholders to give you some terminology. There are multiple. I'm not going to talk about this because others in their presentations will do so. Just know that there are many layers. This is not the diagram that's in your current set of guidelines, but this is. And just to say that there are really many ways that you can engage. And so you have multiple stakeholders, you also have multiple routes of engagement. So once again, breaking out of that community advisory board model, good participatory practice is really about thinking holistically about your environment, from everybody, from your participants to your PIs, to your media, your local blogger. So sort of moving from where we were now into where we are now, and hopefully where we're going and why TB vaccines, why this is sort of a critical piece. One, GPP it's really everywhere. It's really come alive. These are just a handful of publications. And I give you this smattering to say that it's happening in India, it's happening in South Africa, it's happening in Kenya, it's happening in Thailand, it's happening in Latin America, in particular Brazil. And when you see all of these spaces happening, it's happening where TB vaccine research, where TB research is happening. And so it's almost already a part of the fabric of your communities. It's things that stakeholders in those areas will be looking for. So right now is sort of the crucial time to engage. And then the time is now because the research is happening. There's such a robust pipeline in TB vaccines. And we don't want to wait until you do have phase 3 large-scale clinical efficacy trials. You need to think about it now. Now is how you build the road to product rollout. Now is how you think about research dissemination. Now is how you think about engaging with stakeholders about what they want to see as far as post-trial access. What do they need for their families? Post-trial access in vaccines may not be them, but it might be, well, what about my son or my daughter, or things like that. And how do we start thinking through those questions, which might and will almost certainly come up. And the time is now. Once again, this is also from your lovely TB Vax as well, but the time is now, and engagement happens as a process, and it happens throughout. Now is where you need to think through identifying what are your goals of your stakeholder engagement program. How do we move TB vaccines forward? How do we build champions in this field? And all of this really relies on stakeholder engagement. It's going out to your thought leaders. It's going out to those individuals who are immersed in the field and saying, what more do we need to get done? Preparing those things. And then once again, in all plans, we need to evaluate and regroup. So we always need to take a step back and say, is what we're doing helping us walk towards our goal? And so just where do we go from here? Just to say that engagement it's moving forward. And I mentioned a lot of different good participatory practices, and hopefully solidified to you that this is really the time as far as funding and research streams to really begin to unite the TB community. And it's starting with building centers of excellence. ERIS is doing a great job of building their sites as really a coalition anchored around engagement. So it's not just preparing drugs, it's actually thinking about, okay, well, what does the community want and how do we get their input and buy-in? How do we engage PIs and other medical professionals in that? Demonstrating the value, so we always need to think about, okay, what does our engagement program look like and how do we share that with the world? And so moving, once again, away from sort of just thinking about blog spaces, but more published research and real developing solid tools. And then identifying common standards and practices. We all work in a multi-site, multinational area, and while there is varying degrees between countries, we also want to think about what does it mean to standardize this? And as I mentioned, the GPP TB Vax really does a wonderful job of taking theory and building it into practice and giving you a set of clear steps from analyzing to evaluation on how you move through that process of thinking about GPP and implementing it. So being able to come one step closer to identifying common standards and practices. So with that, I just thank you, and you can always stay in touch with ABEC. Thank you, guys.
Thank you, Jessica. Do you want to take questions now, or should we hold them till the end? I'll consult my co-chair. I think we'll run through the presentations, and then we'll do a common Q&A session at the end of the panel. So our next speaker is Eidi Ruzin. He's based at Vital Strategies in New York, where he's the Senior Vice President, Research and Development. He's currently leading the Treat TB initiative and implementation of the STREAM trial, which I've taken to calling the largest MDR TB treatment trial in history. I think that's still true.
So,
we think so. But it is one that's taken steps to support community engagement in a really forthright way, and so we're eager to hear your experience.
Thanks, Mike. Okay. Thank you very much for the invitation. I'll start with my acknowledgement, which is also the acknowledgement at the end. I'm not the expert on community engagement, and I've learned a lot recently, but it's only to the credit of many people working with me that we've been able to move things forward. So I'd like to give you a little background to the STREAM clinical trial itself, and then talk about some of our initial community engagement efforts that didn't necessarily go that far, and maybe we'll see why, and some more recent expansion into community engagement, some successes and challenges from some recent assessments we've done on our work, and a few lessons learned for future initiatives. So STREAM is a clinical trial evaluating shortened treatment regimens, and I'm a little worried about claims, but we say the largest global multi-drug resistant trial evaluating shortened treatment regimens, and then I think we've got it covered. STREAM Stage 1 is a non-inferiority trial that's comparing a 9-month regimen that demonstrated promising results in a Bangladesh pilot project and subsequent cohort studies with the 20 to 24-month regimen recommended in the 2011 WHO recommendations. Stream Stage 2, which is ongoing now, is further evaluating an all-oral 9-month treatment regimen, which is incorporating bedaquiline. It's a complex web of partners, as many global trials are, but this is the crux of Stage 1 anyways, the main funder being USAID and the sponsor being the Union and the North American affiliate Vital Strategies, working with Medical Research Council and others, and the key sites down below, Ethiopia, South Africa, Vietnam, and Mongolia, and I see my colleagues from Mongolia at the back who deserve an extra pat on the back for all the work they've done to develop from a very inexperienced site to a very competent clinical trial site. There's the map of the sites that are in Stage 1 and now moving into Stage 2 of the trial. So quickly on the timeline of Stage 1, we started in 2012. As everyone knows, painfully long process. Over 400 patients enrolled. The anticipated release of the results was Q2 2018, and today is a special day because we're releasing the results early at 6 p.m. Unfortunately, I know there are many competing sessions, but people who are available to join us to hear the preliminary results, we would welcome that. And Stream Stage 2 was underway again in Mongolia. It was first patient recruited in March 2016. Again, it's a slog in terms of recruitment, and we're at about 139 patients and a big road ahead with results expected late 2020. So, community engagement activities. What did we do in Stage 1? Well, we thought we were doing great. We supported community engagement in principle. We encouraged sites to do what they could with community engagement and said it was an important piece of the work. Sites that did initiate their own community engagement, we supported with resources and other supports as requested. But there was clearly limited engagement that took place, and mainly in those that were already comfortable with the concept, those that already had established mechanisms. So at the end of Stage 1, as Stage 1 was coming to a close and we were starting Stage 2, we realized we had to make a greater effort to see progress in this area. So one of the first things we did was strengthen our central resources. I think a TB researcher does not necessarily make a community engagement expert. And we went out and brought Ezio Tavora, who many people might know, into our team as our lead resource for community engagement, and Francesca Conradi in South Africa, who had a lot of experience as well, to guide us. We also raised the expectations with sites. Rather than saying it was a useful tool, we made it clear that we really expected all sites would come up with a plan to engage communities, and we made it clear that resources were available, not just financial, but importantly, capacity building and mentoring would be available. And finally, we pledged to create opportunities for cross-site learning, and as you'll see a little later on, there's quite a bit of, we've been able to bring community members who are working in the engagement activities from several of the sites here to Guadalajara as a first step, and I was in a meeting yesterday with them, and you know, I think it was a really great opportunity just to start to have them share their challenges and experiences with each other. So one of the first things we did in Stage 2 was develop a community engagement plan. Obviously, it was built heavily on the GPP TB trials document from 2012, but it was tailored to the STREAM trial and the situation that we were in. You'll see on the right, and one of my points later on is the challenge of multi-country trials with languages. And you know, for everything you do, it's not going to work in Mongolia or necessarily Georgia or other places without the translation taking place. So I was hoping we'd have some copies here, but anyway, we have a Treat TB booth in the exhibition area, which we have several copies. So essentially, you know, we outlined the steps that we think will work best in the trial. And again, it is going beyond just forming a community advisory board. In fact, we said that it won't be one size fits all, and a community advisory board may not be the mechanism that a particular site uses, but it does start with a broader assessment of NGOs, other stakeholders in the community before determining what's best for that site. Now, it's a bit different in sites where they already have an established community advisory board and mechanism. We weren't looking to create parallel systems. The second thing we did was to try to develop something that would be a little bit more easier to get the concept to people, because I think a lot of people don't. Well, there's not agreement necessarily on what you mean by community engagement. I think that this short learning burst was really trying to give a snapshot for people with, like myself, with short attention spans, so they could get a message of what are we at least talking about and some common understanding. And I don't know, and I usually don't even risk testing technology, but this is supposed to play, and I'm just trying to think without a mouse how that's going to work. But can you, from the back, just press that and see? Oh, there we go. So just to give you a little sense, and I don't know how the sound will work, but we can try. There we go. We won't watch the whole thing.
Did you know that drug trial research has been shown to have better results through community engagement? You might be wondering, what is community engagement? What is community engagement of TV drug trials? And how should it be put into practice? Community engagement is about creating communication opportunities for consultation, education, collaboration, and partnership. It's about building connections between the community and affected people, with researchers and services. This builds trust. And creates ownership in their participation. In the past, little information was shared between those running the research and those affected by it. Oftentimes, this led to mistrust, reduced involvement, and long-term impact on results. But recently, the importance of community engagement in the full spectrum of TV research has been recognized. So how do communities get engaged or involved in research? What matters for most affected vulnerable populations and their community is to have a voice.
So obviously this is downloadable.
We engage the community
again,
by
going
listening
to the language
first to all
challenge,
members
it's one
of
thing
the
to put out in
affected
English,
community.
but to then
And
translate
second,
this into multiple
by
languages
providing
is
transparency
a
and
challenge.
understanding about the research process and its objectives.
See if it lets me.
An engaged community should
I'd
be
like
able to share their
proceed with the
concerns,
slides, but it doesn't
how
seem
they are
to,
affected, and communicate what is
We
working
might have to
and
stop
what is
that,
not.
and then it'll.
This is largely based on the nature of the research.
Let's see. Now we'll go. There we go. Okay, got to go. That's okay. That should work. Great. So again, though we didn't say community advisory boards had to be the way to go, in the sites that have started up so far, they have elected to either strengthen their existing community advisory board or to develop new ones. And you see the community advisory boards that are up and running, both in terms of sites that are actually enrolling and those that are soon, or hopefully soon to enroll. So a few highlights from a recent self-assessment from the community engagement. The CABs, in particular, there's some CABs at sites with absolutely no experience that are flourishing. And one of the challenges with the community engagement, I think, is a bit of hesitancy that we had going to some countries that didn't have a history of community involvement. And we were actually warned in some countries, you're going to get yourselves in trouble, and the trial's going to get in trouble if you're seen as working with the community and the government isn't happy with that. And we found, without naming countries, that it's actually gone pretty well, and we haven't had that backlash. And so there's a couple of sites that we're particularly pleased with. The CABs have already been providing valuable feedback on the trial. We've gone to them specifically with questions a number of times related to modifications that are coming up in the protocol to get their input. We've also used some community engagement activities in countries to go beyond stream in terms of MDR TB awareness in some of the sites. Again, most of the CABs believe in this assessment that they have all key stakeholders involved. They felt they had influenced the trial, And sites have held between 1 and 3 trainings for their own CABs in 2017, and all CABs met at least once with the community to discuss the trial in the last year. Some of the challenges were all CABs reported room for improvement, and that's okay, and they felt they could use more training. And some CABs suggested that even though we've tried, that there needs to be more experience sharing across sites. Some CABs also reported a challenge of keeping members both available and interest up into the trial. Again, here in Guadalajara, we've made a point of bringing CAB members. Well, we were aiming for 7 sites, but I think there were some visa issues. And there are 2 particular sessions on in the Encuentro space led by the different community advisory groups. And I just finished with a slide of lessons learned, obviously, and maybe it's not rocket science, but you know, it's not going to happen unless you're intentional. It's not enough to be supportive of the concept unless you make it clear that it's an expectation of any sites that are participating in the trial, and unless it's adequately resourced, both financial and with human resources and expertise, it won't happen. And again, that mentoring, especially for inexperienced sites, is key. And finally, multi-country trials add a lot of complexity to the issue of community engagement, and language barriers are one important challenge for us. So again, acknowledgements to obviously the trial participants and families and all the people working in community engagement. The trial staff are 2 main resource people and Vital Strategies team that are helping to move this forward at an operational level. So I will stop there. Thank you very much.
Yeah. Okay, so our next speaker is Professor Kirtan Dida. Prof. Dida is the Professor of Respiratory Medicine and the head of the Division of Pulmonology at UCT. His research focuses on epidemiology, diagnosis, transmission, and treatment of TB, and he's recipient of numerous awards for the work he's doing. So we're delighted to have him here. He's going to be speaking about the role of researchers in advocacy, and also sharing with us how to bridge the gap between community and research in driving the research agenda and pipeline. Thank you.
All right. Well, thanks for the kind introduction. I've got some conflicts of interest related to grant funding, but it's not really directly related to the material I'm presenting. So just to give you a brief overview of my talk, so in contradistinction to the previous 3 speakers to some extent, my talk is going to be a more general one, and I've been asked to talk about the researcher and TB advocacy. So whilst I'm going to talk about GPP, I'm also going to talk about TB advocacy in general and try and give you a broader overview and about where GPP fits in. And peppered throughout my talk, I'm going to refer to some examples of research that we've done to show you how this actually occurs. I'm going to talk about advocacy at a number of levels, including the patient and the family, and how we as researchers can introduce new paradigms that empower patients. I'm going to talk about community level advocacy in general about TB. And besides the GPP guidelines, another interesting concept I came across was TB clubs and societies. So I'm going to say a little bit about that, active case finding, and give you an example of what we did in the community. And then I'm going to talk about advocacy at program and at global level, and really this concept of how do we disseminate findings in a way that's taken up by the program. And I'm going to give you an example of urine LAM, right? So urine LAM is a diagnostic test, a new diagnostic test. Some of you may have heard about it. And how this has gone through the whole process of guidelines being developed, but there's been poor uptake, and the need for knowledge translation, and that's a major challenge that advocacy can address. So I think everyone here is familiar with the fact that TB remains the global infectious diseases killer and was already mentioned in the previous talk. Drug-resistant TB is a formidable problem, and the most recent TB, the 2016 report has just come out. showing the increase in drug-resistant TB rates in many of the 22 high-burden countries. And we published these two papers, one in 2014 and another in 2017, highlighting the advent of programmatically incurable TB. So we have a lot of patients who are treated, mainly XDR TB, and who fail treatment, and then many of these patients, because they fail treatment and there are no therapeutic options, are discharged back into the community. It's a major problem in South Africa, and particularly in Cape Town. And this is some qualitative research we did, in contrast to quantitative research, where we explored attitudes and needs of these incurable TB patients, these destitute patients who are living in the community. And I'm not going to go through the slide in detail, but just to show you how, as researchers, we can engage with patients at multiple levels. And this basically uncovered a number of needs of these patients, including the need for companionship and employment and so forth. Now, given this problem of incurable TB, even with newer drugs like bedaquiline and delaminid, we still have a number of people who fail these drugs. The big question is, what is the cause of drug-resistant TB? And there's a number of research groups globally that have tried to address this particular question. There's a number of fundamental research that's involved here. But although there's a long list of causes, one of the things is the poor regimen that we have at the moment. And in fact, that's what the STREAM study is trying to address. And it's therefore not surprising that the current treatment success rates is only about 52%, it's alarmingly low. So another study is the NEXT study, and this is a randomized controlled trial, try and address this particular question and issue. And this is being carried out at 5 sites in South Africa, and the intervention regimen is a backbone of bedaquiline, linezolid, and levofloxacin. It's a 6-month oral regimen in patients with MDR-TB, and has already randomized about 60 patients. Now, at these various sites in South Africa, we had to get a number of approvals at various different levels, including the city of Cape Town and from clinics and clinic managers. And there's been considerable engagement through community-based organizations. This engagement occurred at various levels through CABs, as was outlined in the previous talk. But there was also another thing that we noticed is that we added considerable capacity. So we would provide expertise at these sites for management of patients in TB in general. There were erections of new buildings and facilities, which added capacity to the current TB program. Now, this slide really summarizes advocacy activities as we generally know them that can be undertaken by a researcher: meetings with policymakers, outreach to the media, public awareness activities that we take part in, education and training, and so forth. But I really like this particular model, which is a comprehensive model of TB advocacy. It's published as an editorial in Lancet Respiratory Medicine, the first author being De Luca, and people like Erika Lessem were co-authors in this particular paper. And what you can see here on the top, if you start on the top, there's where research begins. And then, of course, there's engagement with various regulatory agencies and communities, including TB CAB and other CABs. Then, of course, there's the recruitment of patients and engagement with communities, as has been outlined by previous speakers. Then, of course, there's dissemination of results, for example, through publications. And then access to a specific intervention, be it a vaccine or a drug, and a bedaquiline is a good example, where the phase 2b trials were performed, and then there was access to the drug facilitated by various advocacy groups. And then, of course, guidelines emerge, and knowledge translation occurs, where these guidelines are then implemented into clinical practice. And of course, then new questions arise. So, for example, with bedaquiline, We got the drug and we were using it in clinical practice, but the next question arose, how do we actually use these in regimens? And that's the question that STREAM and NEXT tries to address. The point being that this is a cyclical phenomenon and new questions arise, and then you go through this whole process again. So I think this is a very nice all-encompassing model about the TB researcher and advocacy at a number of levels. I'm not going to go through this slide, it's already been discussed. So moving on from there, going on to further discussing other aspects of advocacy at community level, the one thing that I'd like to see happen in Cape Town, and we don't have this, is TB clubs and societies. Examples from a number of different countries. And these clubs and societies not only provide advocacy, they also provide financial and psychological support. Often the members of these societies are former patients, and you may think, well, it sounds like a very nice concept, but does it really work? Does it do anything at all? And in fact, there are 3 controlled studies showing 3 to 4-fold decrease in default rates and significantly improved outcomes with engagements with these TB clubs and societies as outlined in this systematic review. So I thought that was quite interesting and something I think we all need to think about if you're not engaged in this type of activity already. Here's another example. This is a randomized controlled trial in The Lancet. We published evaluating the gene expert technology. There were a number of findings of the study, but one of the findings was that it was feasible to put this gene expert machine at point of care in a clinic, and it significantly reduced dropout. And of course, now there's a miniaturized version of this, the Expert Omni. And what this really is speaking to is the missing gap or the diagnostic gap. So it is remarkable that about almost over 4 million cases remain undiagnosed or unreported, and that's gone up from the previous 3 million that you see in 2013. And so we published this paper. It actually was published earlier this year, though it was published in electronic format last year. And we tried to address this issue by putting together a model for active case finding. And what we did here is we put Gene Expert machine on a van, and we went out into these communities. This is Langa in Cape Town, and this was stationed at various parts of this township at congregate settings, entrances to informal settlements. And this was the first randomized controlled trial showing the impact of molecular diagnostics and how this could increase case detection in the community. The prevalence of disease we found in this community was 8%. It was quite extraordinary. And we've now moved on to a different study where we're trying to scale this to a little van where we can put Expert Omni. In fact, this study is already recruiting. And here you can see the van out here in the community. And so this is an example of a study where there was considerable community engagement, education of the community at large. We had to have quite intensive discussions with various community leaders in the various areas, partly because, and to facilitate the van and the research staff being able to work in a safe environment, right? So in South Africa, when you work in these previously disadvantaged townships, crime is a particular problem, and so you have to engage with community leaders, otherwise carrying out research in these areas is not really practical. And of course, there was screening of household contacts, buy-in of clinics because these patients had to be referred to clinics, and then of course dissemination of results as I showed you. So another example is urine lamb. I don't know how many of you are familiar with urine lamb? Who's heard of this test? Pick up your hands. I'll try and wake some of you up. Okay, so about half the audience. Okay, so this is a test that is thought to be useful in hospitalized patients with advanced HIV, and we showed in this randomized controlled trial published last year 20% mortality reduction with the use of this test when added to standard of care in 4 African countries, and this really underpinned the guidelines we have from the WHO on urine lamb. However, despite engagement with regulatory structures and advocacy groups, and we had guidelines and all that, we still don't have comprehensive uptake by the National TB Program in South Africa, for example, and in fact, in most countries in Africa. And in fact, individual hospitals in South Africa have started doing their own thing and have started purchasing their own tests on the basis of this evidence and these guidelines. And so here's an example of where you have a randomized control trial, you have a mortality benefit, you have community engagement, you have WHO guidelines, but that doesn't necessarily mean you're going to be have uptake of this test at community level, or that this test is actually going to be used. And that really speaks to the whole issue of knowledge translation. How do we translate knowledge and these publications and the knowledge we derive from these guidelines? How do we actually translate that into practice? So this is PAC, or the Practical Approach to Care Kit, developed at the UCT Lung Institute. Some of you may be familiar with this. And what this is, there's been many iterations over the last decade. And what this is a practical handbook to be used by nurses and primary care doctors and healthcare workers in the field, where they can open up this book. It's in a flip chart format, and you can go through an algorithm. For example, if you encounter somebody with cough or suspected TB, it's a step-by-step guide on exactly what you need to do in a primary care clinic setting, and all informed by pragmatic trials. And 4 South African RCTs have shown modest but consistent improvement across a range of outcomes with this particular tool. Now, I'm not going to go through it in detail, but here you can see, so this is currently being used throughout South Africa. It's the tool that's available in every primary care clinic, telling the healthcare worker or the nurse or the doctor exactly how they need to go about approaching a patient who may not be producing sputum and where TB is suspected, etc. And you can see from this map the countries where there's pilots underway, and then several other countries that have expressed interest in this. And then finally, just to mention that this year we published this commission in Lancet Respiratory Medicine, which is a comprehensive treatise on drug-resistant TB. And if you are interested, there are specific chapters in here, and TAG was co-involved in this, and so was TB-CAB. And there's sections on patient-centered care for drug-resistant TB, and also a section on community-centered care for MDR and XDR TB. So I think my time is up, and I'm going to stop there. And so in summary, I think, as was alluded to early on, HIV is a very good example how advocacy at many levels can accelerate change. I like the model that I showed you, which is a self-sustaining circle. Research drives advocacy, and advocacy drives research because it raises new questions and new perspectives. And although research drives new approaches and paradigms, of course, where community participation is important, knowledge translation is critical, as I showed you, but we still need advocacy to drive and highlight the importance of knowledge translation. And perhaps we really need to dedicate funding for this purpose in national TB program budgets to make sure this happens. So I think I'll stop there. This is my last slide, and this is just to highlight that no matter how much of knowledge translation and guidelines we have, unless we address the key drivers of tuberculosis, which is poverty, and we have political will, and we address the key drivers like HIV and smoking and biomass fuel exposure, unless we address these issues, we're not really going to get on top of this disease. So I'd like to acknowledge the co-workers in my group and many of the agencies that funded this work. Thank you.
Speaker on the panel today is Vela Mlola. He's the Community Engagement Coordinator at Task Applied Sciences in Cape Town, South Africa. It's a clinical trial site responsible for engaging the community and the community advisory board there. His reputation for community engagement work precedes him. He was an honored guest at a CAB meeting I coordinated last year, and he's involved with many different trial networks and initiatives. So over to you, Vela.
Hola. My name is Vela Mshola. I'm working for Task Applied Science. I'm just going to give you a background of Task Applied Science. Task Applied Science was established in 2005 by Andreas Dagon. We are based in Cape Town in South Africa. We've got about 7 sites. We've got inpatient and outpatient services. We conduct studies around TB drugs, drug-resistant and sensitive TB. And we do vaccine studies. Currently, we do GCP training as well. We started introducing community engagement program back in 2010. As you can see, there's some of the pictures of our sites, especially where we do our vaccine studies. That's the bus that we normally use to transport our community advisory board members. Just to give you my role at Task, I'm a community engagement officer. I engage stakeholders in the community. We've got 2 CABs. We've got a CAB in a community called Delft in Cape Town, and we've got a CAB in Fulani. One CAB is focusing on sensitive TB strategies, and one CAB is focusing on drug-resistant studies. We also do monitoring and evaluation for impact of CE. We conduct meetings, we do research literacy training, we facilitate protocol input sessions, and we do outreaches. A brief background about myself. I started working in the community. I joined Community Advisory Board in 2010, and it was introduced to me in a form of a meeting in a community. And when I started joining the CAB, there was this meeting, and there was this guy. He was talking about these big words that I couldn't understand. And he started talking about community engagement, that you can really involve people in the community to develop drugs. Then that's when I was interested. Then back in 2013, then I started working for Task Applied Science as a community engagement assistant. Then in 2015, then I was in charge of the program. What is the meaningful community engagement? Is to understand different cultures, norms, and beliefs, identify needs and challenges, and link them with the research benefits, plan activities and budget, implement activities to address the needs and challenges, feedback processes, steps and principles, good participatory practice, GPP. Just to mention, one principle that is very important in GCP is respect and treat people with dignity, transparency. I think that's one of the important principles in terms of GPP. Yeah, this is one of the activity, I think that's one of the big activity that we normally conduct in Delft, whereby we invite both communities from Fulani and Delft, and we'll have this soccer tournament just to raise awareness around TB research and TB itself. As you can see there, this is one of our investigators. Effective engagement. We understand cultural differences. We communicate in a way which aligns with cultural needs. I'm just going to give you an example. If you want to engage a traditional healer, you have to understand, because if you go to a house of a traditional healer, you have to take off your shoes. And you have to, in order for the traditional healer to understand you. Identify needs and barriers of stakeholders, traditional healers and traditional leaders, clinic staff and teachers. That's very important. When you're mobilizing your CAB must represent the whole community. If there's Muslims in that community, you have to have a member of the CAP coming from the Muslims. If there's traditional healers, you have to have a member coming from the traditional healers, because these people will help you to engage these people better. Okay. And take research to the community, yes. Okay. Yeah, as I've said, this is our CAB meetings. Each and every CAB member in our CAB, they're representing stakeholders that are active in the community to make sure that the information that we give them, it doesn't stay there. It covers the broader community. We do training to build trust in terms of the consent processes. So we go to the community and we do trainings around the consent. And as I've said, we do the research literacy training. But mainly we focus in terms of the consent, because that's where the community mainly they need to understand in terms of research. Because consent form is an important document when you're conducting clinical trials. Be transparent about the benefits and risks of research. Yeah, that's very important that in the community, when you do these trainings, you need to be transparent. What's the benefit, what the risk that can happen when people are participating in the study, to build trust amongst the community, which also speak to the GPP. This will improve people's willingness to participate, obviously, as I've already said. Yeah, we do outreaches. Mainly, when we do outreaches, we focus with clinics. And this, in many cases, it improves recruitment, because we support them in terms of the music systems, and if there's in that outreach, there's catering that is needed, and CAB members can help the clinic to recruit people to come and test. Engaging community. Community engage early throughout right up to result dissemination. Community will continue supporting research, and they will also advocate for the drugs, vaccines to be made available because they were tested in their community. Community engagement is for people. It ensures that no one gets left behind. Key principles of community engagement is Ubuntu, which is humanity, which also speaks to the GPP. Thank you.
Open it up for questions. The good news is we have a lot of time for discussion. Thank you to all of our speakers for staying on time. That has never happened before in the history of a union conference. So think about the questions you have. I have to run this mic to you, so just put your hand up. I'll come to where you are in the audience. While you're thinking, I'll maybe pose the first question just to kind of get us going. And I'll go back to Jessica, who started our session off with the kind of introduction to everything that followed and explaining what GPP is. You had this really interesting comment that it kind of sits alongside the other Gs that we know: good manufacturing process, good clinical practice, good laboratory practice. And one of the goals is to kind of incorporate GPP into regulatory reviews. So have there been efforts to elevate GPP to the level of the other G acronyms, and what do you think it'll take in your estimation to get us to that point where this isn't something we have to advocate for every time a new trial starts, but it just becomes a regular part of expected research? You can come up here, yeah.
It's true, I've never had this happen before where we're actually on time. Yeah, so it is a really good question. It's not by accident that it was called GPP, good participatory practice, and the hope is that it would become part of that standard checklist. I think some of the barriers are that we don't have a standard set of practices yet across diseases and really across sites. That's something we're working towards. As it has really rolled out in the last 5-6 years, we've really seen more sites and more trials adopting it, which means that we have more examples to show of really top-down sort of adoption of that and more practices. What is it going to take to be part of the regulatory process? It is a great question. It is a question that sometimes, I'm not going to say keeps me up at night, but certainly I wake up and think about. I think there are a lot of steps that it's really going to take both advocacy and I think sponsors taking that on and really saying, okay, this is an important part of the clinical trial process. And once that happens, then I think regulatory bodies and others will follow. But there are projects to sort of skirt around the edges, which is to train ethics review committees and other stakeholders in good participatory practice in hopes that we get more advocates as well.
Before Jessica goes, and there's enough time, so I'm going to steal another question before we open it up. You were speaking in your slides about the fact that now with GPP, TB, VAC, we've come to some more common GPP principles and practices. We've done, HIV prevention, TB drug, TB vaccines. So I feel, and now obviously Ebola and emerging pathogens as well, it feels like there's almost like enough information already to start moving towards maybe a generic GPP because there are so many disease areas that aren't covered. And in order for it to become a regulated set of guidelines, we'd need to have something that could be applied to other disease areas. How do you see us getting to that point? Do you have any ideas?
Yeah, so as I mentioned, there was a think tank, and that really brought together what we would consider to be the leaders of good participatory practice. Some members in this room here who are really sort of pushing the envelope, both in the way they implement, but also in the way that they are trying to get sponsors to continually push the envelope there. I see both a group like that, but then leading that development of what I will call GPP 3.0 or GPP that is disease agnostic. But I also think that I don't know what page it's on, but if you look at your TB vax, that process that really looks at analyze to evaluate, that's something that's happening in a lot of good participatory practices, that's happening on the ground. There are different iterations in the way that there are different considerations, but the principles are the same. The idea that we respect, the idea that there should be stakeholder autonomy, that there should be transparency, that's true of all the guidelines. So there's actually more that unites them than there is that divides them. And I think moving the field towards recognizing that, seeing, like I said, the process of implementation happen, developing that standard, then we can start to think about a 3.0 or disease agnostic good participatory practice. Yeah, I'm going to steal water.
All right, now we open it up to you. Questions from the floor to any of the panelists today.
Actually, my question goes back to that slide you projected around the cycle where the TB cab and different groups intervene. Yes. The life cycle. Yeah, the life cycle. So, knowing that in TB we struggled a lot to kind of like increase the level of funding, and knowing it's most of the funding that we're seeking now is behind governmental funding or philanthropies that are funding the research, I'm wondering if there is a space in that life cycle to add maybe a fifth one where communities can influence donors in the way they shape up the pipeline or shape up the upcoming or even the direction in which the research is going. Because when Dr. Dida showed, basically when you review the protocol and you want to add another arm, that has financial consequences that the scientist or the researcher has no decision on later in that stage. So I'm wondering if we can think through this option.
Yeah, I think that's a very good point. So as I said, my talk was more about advocacy in general. And as you know, as was outlined in the latest global TB report, the TB is grossly underfunded at every level. And so the first thing, I agree with your point. I think it's a valid point. And I think in TB advocacy in general, I mean, this is critical. So as Oscar Wilde said, he says, money is not everything, but it ranks up there with oxygen. And there's not a lot you can do without it, but I think there needs to be a lot more community engagement about these issues, because it is a disease that's far from eradicated. In South Africa, for example, and in many sub-Saharan African countries, TB is the commonest cause of death now, officially. And you know, the rates are what we saw in Europe 150 or 200 years ago. And it's devastating to communities. We don't have a good idea about the economic impact of TB. So for example, what impact TB is having in terms of GDP on a particular country, that information, in fact, is that basic information is not even available. So I agree with your point, and I think we need, you know, apart from that particular life cycle diagram, if I can call it that, we need community-based and organization-based advocacy about increased funding for TB.
Kirtan, while we have you here, there was something that you raised in your talk as well about the support groups or the clubs. And that really stood out to me because we did some advocacy training, so they're here in the room, some people that were training up to be advocates for TB vaccines. And one of the things that they mentioned was that people are reluctant to become advocates because their experience of TB treatment is so traumatic. And so it's difficult, once they've been through it and they're cured, to get them to go back to having to relive that experience as they become advocates. And the point you just made now about needing more advocates, I kind of see a link between those clubs and that support, enabling us to get more advocates out of it.
No, I mean, I concur with your point. We don't have TB clubs, as far as I know, in South Africa, and particularly in Cape Town. So when I read about this, I thought it was a very important concept, and it's evidence-based. I mean, they controlled trials showing impact. So maybe, I don't know, other people here can comment if you have experience with TB clubs and societies, or maybe some of the people you referred to can really comment on that issue.
I know MSF has cure parties. When they get to the end of treatment, MSF has a cure party, and I think that's really appreciated. Does anybody want to comment on that or another question?
Not on the clubs, unfortunately, but I have a question for Villa. You mentioned that one of the tasks is that you do also some is it monitoring and evaluation on the impact of CAPS? Sorry, I didn't introduce myself. I'm Wim van der Velde from the TB CAP, and we've many times had that question about what is the impact of CAPS, and I know that Stephanie has done a lot of work on that with the TB Alliance. I'd like to hear your view. I think they have impact. They don't need to be. That doesn't need to be demonstrated. But what is your point?
Okay, thank you for your question. The tool has just been introduced by TB Alliance. Currently, we're focusing more on stakeholder engagement, and what the tool does actually is you install data on the tool, and the tool will tell you exactly when you're taking out the reports on quarterly basis. Then the tool will tell you exactly where you're lacking in terms of engagement.
So I was just going to say, I think one of the pieces on monitoring and evaluation that is really, at least to me, is critical is this idea of coming up with a goal. And the critical path for tuberculosis, the APTR, TB Alliance, and others came up with, and TAG, all...
I don't want to take credit.
Really worked with a researcher named Kate McQueen to think about a theory of change, which is really how do we get the field to come up with a goal? What is our goal for engagement as a tuberculosis field? I think TB vaccines can really think about that as well. But, and I didn't catch your name in the blue, so I apologize. But I think it speaks to your question as well, of how do we engage champions in this work to create a sense of advocacy that can start to move the field forward. And I will say I'm stealthily coming into the union conference because I actually come from HIV. And so when we think about our advocates have a goal, and I'm wondering, what is the goal of the TB field, and how do we unite advocates, but also, to be honest, researchers, PIs, physicians around this goal to become champions and advocate for additional funding for more work streams, and then monitoring that progress. So just sort of trying to link things back.
Yeah, hi, Diego Silva from Canada. So I actually just had a question for Jessica, so I'm going to get you to get, but anyone's free to answer this question, but it's actually right on monitoring and evaluation. So I guess it's on everyone's mind. So could you speak more, could you expand on that point that you said that it's being developed, whether for HIV or TB, GPP more broadly? What are the measures actually looking like? What is trying to be measured and evaluated? I'm wondering if you could speak more to that point.
So there's a fabulous paper on this theory of change and on the work that they've done. So right now there is a theory of change for TB, and it maps out what is the ultimate goal, and there is a goal statement, which I do not have memorized, so I'm not going to try to say it. But then it actually does have 5 different criteria that looks at community mapping as one. And maybe, Stephanie, do you remember exactly where we can get the paper? But this Kate McQueen article from their theory of change piece. Empirical methods. If you come up after, we can connect you to that. But it really goes through the clear pathway, and this took several months to really develop and used a working group to come up with that. HIV is actually behind in that space. We don't have that. What Vela was talking about is there's a toolkit that TB Alliance really drove, and AVAC has helped, a little put together, but on coming up with where you input data, but it's a complete online resource which goes through, mapping out to GPP. So thinking about what is your landscape, what is the engagement, who are you engaging with, and then linking that engagement activity with that stakeholder. And the idea is that what we all hope to do is move the needle, right? We want to make somebody who's skeptical neutral. We want to make somebody who's neutral a champion. And how do we actually know that we've done that at the end? It's very hard to measure a negative. So just saying nothing bad happened is not necessarily something we can move forward with. So we want to change that and to really start to think about, well, how much impact did this one event have by getting more favor or less negativity in a community space, and then over time thinking, did we decrease stigma? Did we increase knowledge? So that's what that toolkit is trying to do. That's what the theory of change ultimately hopes to do. And in that space, TB is actually much further along than HIV is. I don't know if that answers your question completely. Probably not, but that gives you more information.
I will just, if I could just give a clarifier to the tools that we put together. So they have been implemented and tested for a while. I think that what we're seeing from the data that we are able to collect is that we're looking at, as Vela mentioned, engagements and trying to tease out what are the power of relationships that we're building through community engagement and understand what kind of interventions we do with broad communities that really do help to move that needle and build stronger relationships. And make sure that we're doing the right kind of work to identify community leaders that have influence, not just to have positive perceptions of clinical trials, although we're working towards that, but helping us to identify the right kind of stakeholders that are the key stakeholders to engage with throughout a clinical trial process. That's where we are right now. And if you have any other questions about the tools, come and talk to me. They're not as widely implemented as we would have liked. But
Thanks, Stephanie.
Hi everyone, my name is Tandy from Johannesburg. My question is, I think any of you can actually answer. So I have this thing, how do we make TB awareness as sexy as what HIV awareness is? I mean, how did HIV awareness surpass TB awareness when HIV is a baby compared to TB? So what are those things? And I think it was you, Doc, who had a slide that said what we can learn from HIV. What can we actually learn from HIV that we can apply? And also linked to that, and maybe to you, Vela, is how do we move community engagement beyond just what is TB? Because that's where we're stuck in Joburg. We get stuck on what is TB and we don't really go into then the studies because the basics are not in place. We find that even in places, in corporates, where you think people, they actually don't know. So we still spend a lot of time educating people on what is TB, and we don't get enough time to then talk about the studies that are happening.
Yeah, so I think I struggle with this question, and having been here now, I really struggle with this question. My totally opinions, but I think there's a few things. Number one is you can't cure HIV right now. So there is more of there's more of a willingness for people who are long-term survivors to say, I'm a long-term survivor and I don't want to see you go through this. HIV at its essence, right, can be sexy. You can talk about condoms, you can talk about lube, and you can bring those into spaces. And I do think in some ways that helps rally around a community because people want to have sex and they want to have sex safely, and that is a main driver. And if we're being honest, I think that we can talk about that. And in the beginning, if you think about the HIV, there was no sort of large-scale global complex the way there is now. And so HIV advocates were, at least in the US, dying, and it seemed like they were ignored, and then there was this sense of ownership of we must do this. And it was also happening to a community that was disenfranchised and isolated and marginalized, unfortunately. And so there was also this other sense of anger that was happening at the same time. So there's both a historical element that I think was happening there, and you're right, HIV is a baby compared to TB, but I think those are some of the differences. And like you said, there's a literacy element there. People don't see that it's a problem, or they don't know what to do until they are sick. And once you are sick, you don't necessarily want to be an advocate at that moment. You want to get better. And so that's sort of where do we change that narrative, and when do we introduce literacy, and then how do we once again bring those people in the know to become champions. And that's just my thoughts. I don't know.
Any other thoughts on the first question before we move to your second question? All right, so your second question about how do you take community engagement to more than just literacy, right?
So I guess organizationally, so like at the union, one of the things we've done is to bring in a civil society officer or liaison person who can look at things beyond just a particular research project, to look at some broader areas of concern for the community. I think it also comes down to resources and time, because I know you're busy at your cab, and so you only have so much time to discuss the issues that are at play. And I'm not sure if you saw earlier when I presented some of the feedback from our cabs and stream, some of them were, there wasn't enough time for people lost interest in terms of availability, so you can't keep bringing people back 3 times a week to discuss additional issues. So I think it's a bit of capacity of the individual cabs as well. I just want to say something about budget as well, because of I think I was asked before when we had one of our preparatory calls about the responsibility of an organization like the union to ensure you do community engagement, and we don't fund our own research, but I think that the role we have is to make sure it's in any proposal we put forward, and almost to demand that we can't do the research if that's not included. And some donors, and I will say for Stream, USAID's been very supportive of saying that's okay to have that line item in there, but I'm not sure that every research granting agency or donor would allow to have that in. So I think as a research implementer, we need to push for it, but ultimately the donors have to be willing to fund it as well.
Yeah, I completely agree. I'm going to go to Vela now. And just on that, I just wanted to say, for the union to have given this kind of space to GPP was fantastic, because I think Mike mentioned it. It's the first time that this has happened. And we need something to make sponsors and funders aware that this isn't an optional. This is a mandatory. So yeah, thank you for that. So Vela, your experience.
I think from my side, the main challenge, the stigma is still big in terms of TB, and especially in the workplace. It's difficult to come out and talk about TB if they do have TB, because they are going to be fired, and the employee has a right. And as the speaker before said, the issue of budget, so that we can do bigger campaigns, maybe a radio campaign or a TV campaign, or do a concert that is only dedicated on TB, and have advocates that maybe superstars in our communities. I think that can maybe have impact.
Thanks, Vela. And when Vela and I were talking a couple of weeks ago about how he does effective community engagement, one of the first things you mentioned was budget, that you have to have the budget to do effective community engagement. And when we were developing the GPP TBVAC guidelines, on page 25 is that cycle that's been referenced a number of times: identify, analyze, prepare, engage, and evaluate. And we were trying to put into the guidelines topics of interest or special considerations. And actually, when we were doing it, we wanted to write budget under every single step of study, from when you're doing protocol design to results dissemination. When you're doing your analyze, you have to be analyzing what budget am I going to need to do effective communication for this part of the trial. Other questions?
I think this has been a really nice discussion, and we are coming up at the end of our time, so maybe we'll just sort of quickly summarize and share some final thoughts before letting you move on to your next event. I think Jessica ended her presentation with slides on the way forward, and it seems to me that a lot of what we have to figure out is, we have excellent guidance, we have it for different indications of TB, prevention, drug trials, different pathogens. We have to figure out and move forward the kind of logistical work, which includes budgeting, which is, I think, crucial. And I think a lot of this to date has really been taken forward by public or philanthropic funders who are more willing perhaps to fund CE. We haven't said so much about what pharmaceutical companies do in their large multinational clinical trials based at CROs and other kind of units, which are often doing work with public and philanthropic agencies themselves. So that's a kind of unexplored territory when it comes to the financials of this. The monitoring and evaluation is kind of a perennial topic, and I think we're really thankful to the Alliance for moving us forward with concrete tools for this, and we have theory of change models to see how that work progresses. But even as we figure out the logistics, I think there's still some space to, on a more conceptual note, continue to sort of link GPP to other powerful practices. Vela in his talk mentioned respect, dignity, transparency. These are kind of the ethical underpinnings of GPP. They're also the ethical values that animate the international human rights framework. And so I think one thing that I'm particularly interested in is linking GPP to a practice of international human rights, which is recognized by state bodies and is international law. And how is GPP related to things like the right to health, the right to information, the right to participation, and non-discrimination? Can we kind of bring that language of rights and entitlements into this practice and really back it with a kind of force of international law where appropriate? So that's where my mind is at the end of the session, and I'll leave it with Kristen to share her last thoughts.
Thank you. I could see Anne in the back there practically standing up and cheering you on as you said that. Yeah, I mean, this has just been a fantastic session, and to have the level of engagement from everybody here, when I know there are lots of competing sessions out there, but to have so many people here wanting to talk about GPP, wanting to make sure that we do it effectively, not just as a tick block, but as something that We do because it's the right thing to do for the communities, it's the right thing to do for the products. It's the only way that we're going to make sure that the products that are developed are aligned with what the community needs. And one of the statements that really was on one of the slides that stood out to me was research drives advocacy and advocacy drives research. And that for me was a really good cycle, because that's what we need. We need communities to become empowered to advocate and drive the research agenda. And that is part of what GPP does. And we need funders and sponsors to come to the table and make sure that there is the space to do the planning for effective good participatory practice, and that there's the budget for it. And so we're delighted that GPP TVVAC is now part of the resources available to make this happen. And we'd like to encourage you all to take lots of these copies with you, because we don't really want to carry them home with us. So please take as many as you can, distribute them. You can get copies on our website and AVAC's website. And there's also opportunity to give feedback if you have on GPP in general. I'm sure AVAC would appreciate it. But thank you to our speakers, and thank you to Mike, our co-chair, for a very good session. Thank you.
Thanks.